All right, you guys. Chapter 17, maximizing comfort for the laboring person. All right, so there are two forms of neurologic origin of pain in your laboring patient. We've got visceral and we have somatic. Okay, so with visceral, the pain from distension of the lower uterine segment, stretching of the cervical tissue as it effaces and dilates, pressure and traction on the adjacent structures like your tubes, your ovaries, your ligaments, and nerves, and uterine ischemia during the first stage of labor is that visceral pain. It is located typically over the lower portion of the abdomen. Referred pain occurs when pain that originates in the uterus radiates to the abdominal wall. Okay, so think about your mom who is laboring, early stages of labor. She feels contractions, and so she feels some discomfort during the contractions. She's able to talk through them. She's able to still walk around, kind of have normal functioning. But we know that that pain can radiate to her lower back, to her thighs, and to the gluteal area as well as her lumbosacral area. So that low back pain, right? Okay, so that's going to be your visceral pain. During most of the first stage of labor, the laboring woman typically will have discomfort only when she's having contractions. So when the contraction goes away, she's fine. She's walking around, she's doing her thing. And the pain during those contractions during the first stage of labor, she'll feel like a tightening. I told you guys the best way I can describe a contraction is if you put on a belt and you pull the belt really, really snug till you're like, oh, this is uncomfortable, right? Hold it there for like 30 seconds and then slowly release it back. That is the best way I can stimulate what a contraction feels like. It's super, super tight. And then it comes back and everything is loose. And in between contractions, she's fine. She's doing well. She's walking and not really having a lot of pain. During the end of the first stage of labor, and then the second stage of labor is when that somatic pain or neurologic origin kicks in, which is often described as intense, sharp burning and well localized. The pain results from the distension and traction on the peritoneum, and uterocervical support during contractions, pressure against the bladder and the rectum, stretching and distension of the perineal tissues and the pelvic floor to allow the baby to pass through, and then lacerations of the soft tissue. Okay, that's going to be your somatic. In your book, there's some really good pictures about the distribution of labor pain during the first stage. In figure 17.1. So take a look at that and you'll see the difference between that visceral and the somatic. Okay. Perception of pain. The only thing that I can tell you about perception of pain is there's so many factors that influence how somebody deals with pain. Okay. And we all know, because we're nurses, right, that pain is the patient's perception. So you can look at a patient, which I have done. They come into labor and delivery and they're having contractions. And you'll ask the patient, so what's your pain level? And the contraction's pretty strong. You palpate it. You can see it on the monitor. And you'll have a patient come and be like, oh my, it's like a 3 out of 10. And you're like, okay, great. We're doing this. It's all good. And then you'll have a patient come in who's having a mild contraction that like is a bump on the monitor. And they're like all over the bed. So I say that to say, you'll ask patients what their pain level is, and some will be smiling and be like, it's a 7. And you'll be like, okay, it's a 7. I'm going to document a 7. However, let me explain to you what a 7 feels like. Okay. So just know that whenever it comes to perception of pain, it is subjective and we document what the patient says it is. All right. There's so many things that can affect the perception of pain. How people express their pain. There can be physiologic reactions, as well as sensory or emotional reactions. There's also cultural ties to pain. And I think we talked about that. You'll find some cultures that come in and the women are so stoked that they like literally, they will be in dying pain and they will just lay there like this. And you don't even know they're in pain because culturally they've been told that we don't express our pain in an outward perspective. However, I will tell you, in labor and delivery, at some point, I've yet to see a woman not have some form of a cry out at some point in her pain. Natural labor patients, even patients with epidurals. Epidurals help you during the laboring process, during those stages of labor, the first and second stage of labor, when those contractions are really intense. But the other piece of that is as you're delivering the baby, that perineal pressure, epidurals will dull it, but there's still pain there, right? So our goal with pain management is to keep the patient as comfortable as possible, the best that we can. Okay, so our factors influencing pain response are going to be physiologic, and we talked about that, and then cultural. We know that cultural beliefs and practices affect how a woman and her partner cope with labor. Okay. Some cultural reactions to pain. They may not exhibit reactions to pain, which I just talked about. They may believe that accepting something when it is first offered is impolite. Therefore, pain interventions must be offered more than once. They may be vocal in response to labor pain and express pain openly. We have some women that come in and they sing. That's their way of relieving their pain. Some come in and yell. Some come in and beat up on their spouse. You'll see a little bit of everything in labor and delivery, I promise you. Some may endure severe pain before requesting relief. I hear women say all the time, oh, I want to know what it's like to be in labor. And I have told you guys, one good contraction, thank you. I know what labor feels like. I will take my epidural now. Okay? My pain level threshold is not high at all, and I have no shame in telling you that. Epidural all day long as soon as I walk through the door. I want to have an enjoyable delivery. I want it to be memorable. I don't want to be screaming and yelling and kicking at people and crying because I can't tolerate the pain. Okay? There's anxiety that's commonly associated with increased pain. So you may see mild anxiety is considered normal for a woman who is in the labor and birth process. Excessive anxiety and fear, however, cause more catecholine secretion, which increases the stimuli to the brain from the pelvis because of decreased blood flow and increased muscle tension. So that's why we tell women all the time, like you see a woman when she gets a contraction, she tightens up and just every muscle in her body is tight. Well, when you do that, it doesn't allow the uterus to do its job because everything is tight. So it decreases circulation because we're grasping and holding on to things. So I always try to tell women for that 60, 90-second contraction, take your mind to a place that's relaxing and comforting for you. Try to let every other aspect of your body go limp, which is hard to do, right? But if you're guiding them, do that guided imagery and guide them through the process. Okay, mom, you're hitting the peak of the contraction. You're doing great. Keep breathing. Relax, 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 relax. And then now the contraction is coming down. That's what we call guided imagery. So you're walking her through, okay, this is 60 seconds. I can do this for 60 seconds because I know at the end, I'm going to get a break. One of the other things I do for my moms when I'm in labor and delivery, they scrunch up. And sorry, my scrunch isn't good. I'm a toxer. So, but I put my thumb right here. And just the presence of having your thumb there causes their face to relax. And when the face is relaxed, the rest of the body will relax. So I will do that for them while they're having a contraction, as well as that guided imagery of talking them down through the contraction. And I've been pretty successful with that. Their previous experience is going to play into how they respond to their delivery. Whether they had a good experience the last time. Was it an emergency? Did they not get an epidural and they wanted an epidural? So all of those things are going to be key factors on what her overall experience is when it comes to labor and delivery and her pain response. Gate control theory of pain. The gate control theory of pain helps to explain the way hypnosis and pain relief techniques taught in labor and birth preparation classes work to relieve labor pain. So that's going to be your childbirth education classes, like your Bradley method, those breathing techniques, moving around, using the peanut ball, taking yourself to a place of meditation and Zen to help control labor. Some people are really good at it. Some people not so much. Okay. And then comfort. Is she comfortable standing up? Is she comfortable laying down? Is she comfortable in the shower? Is she comfortable soaking in a tub? All of those things are options and ways that we can look at to help alleviate some of the pain in your laboring mom. And then last but not least is support, right? She's got somebody there coaching her, babe, you can do this. Sis, you've got this. You know, you're doing a great job. You're doing amazing. Your body is wonderful. All of those positive affirmations are so, so helpful in labor and delivery. Even if she has to, she comes in with the mindset of, I don't want an epidural, and she ends up getting an epidural, it's okay. Like, you need to let her know it's okay. Like, I want you to enjoy this experience. I want this to be something that you remember. It's life-changing. And so if I can have you comfortable and really be in the moment versus thriving all over the bed and crying and kicking people, that's something that we can do. We can help you with if that's your choice. Okay. The environment plays a role. Is it a home-like setting? Is it a medical setting? Are the lights up bright? Is there music playing? Is there aromatherapy? All of these things can be incorporated to help with pain relief in your laboring mom. Okay, so next we're going to talk about the non-pharmacological pain management that is available for your mom. So from a non-pharmacological management perspective, we've got counter pressure, where you're putting pressure on that lower back and helping her. Effleurage, which is like a light massage where you're just doing like feather-like strokes along the body. And this can be anywhere, along her arms, along her belly, on her legs, wherever, she finds the most comfort. Therapeutic touch and massage, walking, rocking, changing positions, application of heat and cold, transcutaneous electrical stimulation, nerve stimulation, TENS units. A lot of natural labor patients will use those. Acupressure. We talked about water therapy, whether it's the shower or the bathtub or a whirlpool tub. And then they also have intradermal water blocks. Sensory stimulation strategies are going to be your aromatherapy, your breathing techniques, your music, imagery, and focal points. And then we've got cognitive strategies like birth education. So taking those classes ahead of time so that you really understand how the body is transitioning through the phases of labor. And then also hypnosis. Now, I've never seen it work. However, it is an option for non-pharmacologic pain management. Let's see. Did I miss anything? Box 17.2 goes over those non-pharmacologic strategies to encourage relaxation and reduce discomfort. So those are good to know. They get into all the different types of breathing techniques. I'm not going to ask you about those, so don't waste your time on them unless you're just really interested. But I do want you to know some of the ways that we can reduce pain in the laboring patient from a non-pharmacologic standpoint. All right. Let's go to pharmacologic pain management. So when we talk about pharmacologic, there are several methods that we can use. First on the list are going to be our sedative medications, which relieve anxiety and induce sleep, but they do not provide analgesia. So that's going to be like your barbiturates, your phenothiazines, your benzodiazepines. In labor and delivery, typically we will utilize Stadol is the number one that we'll use. For our patients. Again, Stadol does cross the placenta. So whatever we're giving to mom, we're giving to baby. So that's going to be one of those medications that you definitely are going to have to be sure that you're assessing your patient regularly. For me personally, once mom reaches a good 5 or 6 centimeters, I typically, especially if she's a multip, she's had multiple babies, they tend to transition in second stage a little faster. So I'm not comfortable giving those patients IV medications because then what happens is you give it to them at 6 centimeters and then 30 minutes later, she's complete, and now my baby's sleepy and needing some form of resuscitation. So what you'll find typically is when we're giving sedatives, we do those early on in the latent phase of labor, that first stage. They do take the edge off, but they don't make the pain go away. So basically what you'll see is when mom has a contraction, she's like kind of awake, kind of moaning, but as soon as the contraction goes away, then she falls back to sleep. Okay. Also on our list, let me see, I don't see it in here. Sorry. I don't think the book has it, but we'll talk about it because you'll see it. Is nitric oxide. Oh, it is in there. Okay, it's in the back. So we'll go over that after epidurals. Okay, so from our pharmacologic pain management, it is acceptable for women in labor to endure severe pain when safe and effective relief measures are available. We talked about those sedatives. The barbiturates we seldom use in obstetrics. The phenothiazines we seldom use. The benzodiazepines, when given with an opioid analgesic, pain relief is enhanced, but nausea and vomiting are reduced. So we find, that sometimes those are good measures to utilize those sedatives in the early latent phase of that first stage of labor. From a pharmacologic pain management perspective, typically what you will see in the first stage, we've got our opioid agonist analgesics, our opioid agonist antagonist analgesics, that epidural block or anesthesia, and then nitrous oxide are used as well. When we get to the second stage, we've got a nerve block analgesia and anesthesia. Sometimes you'll see a pudendal block. Pudendal blocks are done just on the lower region, the pelvic region. Don't see them a whole lot. Your old school docs, remember we talked about old school docs delivering with forceps? They're really good at pudendal blocks. These new guys, not so much. It really is basically to numb that pelvic floor area, and you have to get a spinal needle all the way in, not stick the baby and get in the right spot. It's kind of difficult to do. A lot of the times, and most people that do it, unless you know what you're doing, aren't successful with it. So mom still ends up being in pain. What you typically will see mostly in the labor and delivery suite is going to be that epidural block. And then, of course, that nitrous oxide. For vaginal births, definitely the epidural. For cesareans, if she's coming from labor and delivery and already has an epidural, they'll typically top that off to numb her from the waist down. Because remember, with epidurals, we still have some physical movement. Not enough that she can get up and walk, but she's able to still move her legs, toss and turn. Once we enter that spinal space, however, now we've completely shut down the nerve block. So if she's coming from labor and delivery with an epidural for a C-section, they'll top that one off, may do a 1-dose spinal, and then remove that epidural after she's delivered. But if she's a scheduled and she's just coming in for a C-section, the majority of those patients are going to get that spinal epidural. So you give them that spinal and lay them down. We get baby out, and then they get a continuous PCA post-delivery for pain management. All right. I'm not going to go into the opioid agonist analgesics. So they get into your morphine sulfates, your fentanyls, and really, honestly, it's all going to depend on what the physician orders. Like I said, most of the time we're using like a Stadol or a Phenergan combo in labor and delivery. And I just want you to know what are the pharmacologic versus non-pharmacologic. So don't waste your time looking at the dosages and all the different medications. I want you to know what the options are for the patients that we typically see. I talked about that Stadol. The other one is NuBane that we utilize. And those are opioid agonist, antagonist analgesics that are safe to use in your laboring patient, but do cross the placenta. So if you're giving those sedatives, know that they can have a respiratory effect on your babies. Okay? Always, always, always we keep our Narcan nearby, because if we do give those medications and we end up with a baby that's in respiratory distress, then we'll give baby Narcan to have the reverse effects of that analgesic. Nerve blocks, analgesia, and anesthesia are typically what you will see in labor and delivery. The pain pathways are different when you're doing a pudendal versus your epidural block. Your pudendal, again, is going to be in that pelvic floor region. Your epidural is going to be in the lower segment of the spinal column. and both are done as sterilely as possible. Anesthesia is doing your spinal epidural, and your pudendal block is actually being done by your OB or delivering physician. Your book goes into a lot of detail. Most of the time for placement, we're doing a sterile prep, and the patient is either sitting up on the bedside or they can be sidelined for anesthesia to place that epidural. One of the biggest things that we're going to monitor post-epidural is going to be maternal hypotension with decreased placental perfusion. So what you'll see is mom gets her epidural, her blood pressure drops, and now baby's heart rate drops. So always we keep ephedrine at the bedside. In most labor and deliveries, your anesthesiologist writes an order on how to treat mom if she experiences hypotension. And if that treatment is unsuccessful, then you call them back and they come back to the bedside. Just depends on your facility, on how much management you have with that continuous epidural. But we do track the amount of epidural that they're getting. So most will get a loading dose at the placement, and then they go on continuous epidural, where we attach a catheter and they're continuously getting medication until they deliver. Once delivery is over, we stop the epidural infusion, and then typically the nurse will pull the epidural catheter, post-delivery. Side effects of the neuraxial anesthesia are hypotension, which we talked about, local anesthetic toxicity, lightheadedness, dizziness, ringing in the ears, metallic taste. You'll find that when an anesthesiologist is placing the spinal or the epidural, he'll be asking the patient, let me know if you feel, nerve symptoms more on one side than the other. Let me know if you feel a metallic taste in your mouth. Let me know if you feel dizzy or lightheaded. They're looking for all of those things. Fever, urinary retention, limited movement, which we expect, and a longer second stage sometimes. Typically, in the medical market, patients come in, we start them on Pitocin or we augment them with the Pitocin. Next step is the epidural, and then we have a baby. Unless they truly want a non-medical delivery, then we hold back on the augmentation and allow them to labor naturally. Not going to get into the specifics of epidurals versus combined spinal epidurals, but it is a technique used by anesthesia, and that's going to be your patient that I told you, starts in labor and has an epidural placed and now is going for a C-section. So they will pull the epidural catheter, put in a spinal dose, and then follow with a PCA post-delivery. Nitrous oxide is huge, also known as laughing gas. Kind of on the lines of that sedative and how it works and affects in labor and delivery. It takes the edge off. It does not take the pain away. So we now are able to administer as nurses at the bedside nitrous oxide, and basically the patient just has a mouthpiece, and as often as they need to, they can breathe it in when they're having a contraction, and typically when the contraction's over, they'll pull it away from their mouth. It does help take the edge off for some patients. And, it's a good early labor help from a non-pharmacological standpoint. Well, it's pharmacological because it's nitrous, but less invasive, I'll say, standpoint that you'll see moms using that. Works for some people, doesn't work for everyone. Okay. So that's also something to know that is available. And we typically administer that through a face mask, or some floors have the actual breathing mouthpiece. And then general anesthesia. Rarely used with an uncomplicated pregnancy. Honestly, this is going to be your stat emergency C-section where she does not have an epidural in place and we need to get this baby out. We know that with general anesthesia, we have to be careful because it does cross the placenta. And so if we put mom to sleep, we put baby to sleep. For your general anesthesia patients, we know that we are, the woman should be pre-medicated with clear oral antacids. We usually give that to neutralize the acidity of the products in the stomach. We give Bicitra. It's a bicitric acid. It's like a little cup. They drink it before they go in for their C-section. And typically when we're doing general anesthesia, because of the risk for neonatal narcosis, the baby has to be delivered as soon as possible. So what you'll find in those emergency cases is Mom will go to sleep and literally 2 cuts later, baby is out in like less than 30 seconds. It's pretty amazing to watch and see, especially when you go through a scheduled C-section. They kind of take their time going through all the layers. When we do general anesthesia, literally they do 2 cuts down to the uterus and pull baby out, because we want to get baby out before that narcosis sets in. To reduce the degree of fetal exposure to the anesthetic agents and the central nervous system depressants administered to mom. So that's going to be your general anesthesia. Okay. Care management for non-pharmacologic interventions, pain assessment during labor and delivery. Pain scale is often used to evaluate a woman's pain before and after interventions are implemented. So we're constantly asking, what's your pain scale? We always secure a baseline. Labor and delivery is never going to be pain-free, right? We're going to do the best we can to monitor and maintain a comfortable pain level for her, but it's never not going to be any pain at all. Okay, whether you're in pain during the procedure or after the procedure, right? So C-section, you're not going to feel any pain during the C-section. However, when that spinal wears off in the next 24 hours, you're going to feel some pain at that incisional site. And then pain assessment should also evaluate her ability to cope with labor and her overall satisfaction with the labor and birth experience. So it's going to be important that we are constantly monitoring her and asking, how is your pain? How are you coping with your pain? And helping her to develop a realistic pain score. I tell most of my patients, like, there is a level of pain that all of us can tolerate. It may be different for each individual patient. That's where I'm going to try to hit. For me, my pain scale is a 3. Don't laugh at me. I don't like pain. So can I handle a 3? Yeah, for a little while. I'll do my best. But if it starts creeping up past that 3, it's time. I need my epidural. Okay? All right. I think that is everything that I want you to know from an anesthesia perspective. Of course, informed consent for everything. Timing is going to be important, especially for your pharmacologic. You don't want mom to get to a point where she's so uncomfortable that she can't sit still for that epidural placement. So you're monitoring, you're assessing your patient. You come in and you see her moving a little bit more. She's little bit more uncomfortable. Hey, let's talk about your pain management. If epidural is what we want to go, I think now is a good time. You're 5 centimeters, your contractions are picking up. I see that with each contraction, you're getting more uncomfortable, and I want you to be able to sit still long enough for the placement. Now's a good time. It's okay to have those conversations with your patient. Preparation, typically we'll bolus them with 500 mLs of LR just to get that volume up to try to prevent that hypotension that we see post-epidural placement. Epidurals work by gravity. So typically for those moms, we don't ever lie them flat after their epidural has been placed. We'll keep them in that low Fowler's position, again with that hip tilt, because we don't want them to be flat on their backs. That also contributes to that supine hypotension. And so we just monitor them, and then we will rotate them, right? Because it works by gravity. We want to make sure that both sides are equally as numb. And so if mom says, oh, my right side feels like it's asleep, but my left side I can totally move, then we'll tilt her to the left. Put a tilt under that right hip tilt her to the left to let that epidural kind of drift down to that left side a little bit more. I think that's it. All right, so we'll do, I know I won't be with you guys tomorrow, but we will do a little bit of a recap next week. If you have questions as you're going through, if there's something that you don't understand in any of the chapters, I recorded this video last, but it'll be the first video you watch probably. But anyway, if you have questions, please write them down. And I will be sure to address those next week before we start lecture next week to make sure that you have clarification on anything that you need. These chapters are pretty straightforward. Again, for comfort, maximizing comfort for the laboring patient, need to know the pharmacologic versus non-pharmacologic, how we support the patient, the education, and how we assess our patient for comfort in labor and delivery are going to be your key factors. Again, I can't remember if there is an osmosis for this, but if it is, I will tag it or let you know in my note where the link will be posted in YouTube, and you can go check that out as well. Those osmosis videos are really good for summation and really wrapping up the key elements of each chapter. All right? Okay. You guys have fun tomorrow going through this content, and I will see you next week. Bye.